good afternoon, everyone. It's 1 o'clock, so we'll get started. I want to thank all of you for joining our Superior Health Quality Alliance COVID Leadership Roundtable and Office Hours. My name is Kim Heft, and I'm joined by my colleagues, Jerry Hineker and Julie Campbell, as well as our guest speaker today, Dr. Buffy Lloyd Great. Oh, wait. Great. I was gonna, I had it and then I didn't. Well, it looks like Dr. Buffy saved me and I appreciate that. So she will be presenting on the first of a 5-part series on infection prevention and control. Now, for those of you that have been joining these meetings, welcome back. And those who are new to the call, we're glad to have you here. We host this session each week. It's 30 minutes of education where we highlight important topics related to COVID-19, including vaccinations and boosters. And then we follow that up with a Q&A session. You can ask questions, learn from your peers, the speaker, and the other superior health quality improvement advisors. And we hope you're going to be able to join us each week. One thing that I ask of you is to think about things that are on your mind, things that you're struggling with, maybe trying to figure out. We're always looking for future topics. So if you want to send me a direct message in the Zoom chat, maybe we'll be able to add your suggestion to a future session. As a matter of fact, one of our participants has done that, and you are going to hear about the VIRS vaccine site on a future session. So appreciate that. So if you have other topics, please let us know what you'd like to talk about. Now, there's going to be a survey at the end of the session, which will ask you to take just a few minutes to complete, and that will be put into the chat section of the event. And then Jerry's also going to put a link in for the PowerPoint presentation and chat in just a moment or two or a little bit later on. Now, also, please use that chat box to share any comments, questions, or anything else that pops into your mind during the presentation. And then we'll use that for discussion during the Q&A portion of the event. So I think that ties up all of the logistics there. So with that, I would like to welcome Dr. Buffy. The floor is yours.
Thanks, Kim. I'm going to set my timer because I've recently learned that I can talk for 3 hours without any trouble at all. So we want to keep it short and sweet today. So I am super excited to join with you guys today and to be able to be a part of this 5-part series. Thank you to Superior Health for inviting me. I love educating and working with long-term care, of course. And so I'm just really excited about this opportunity. So I want to dive in a little bit and first we're going to discuss really over this 5-part series, but today really the current infection landscape in long-term care. We know what's going on with COVID, but I want to take you back a little bit in history and give you a little idea of what some of the problems were even before this pandemic hit our environment. And then I'm going to explore some common challenges with long-term care within the environment related to our IPC practices, and of course, discuss evidence-based practices. Now, today, we're going to cover hand hygiene practices. And before you yawn and say, we know everything there is to know about hand hygiene practices, hang in there with me. It is my goal to bring to you some common tips and ideas to implement within your facility based on my experiences. And so hopefully you will continue to gain information and learn new ideas for your healthcare setting. As Kim had mentioned, my company is IPC Well, and we are devoted to preventing infections in our long-term care facilities and providing support to you. So I want to start today by saying that we have all been running this marathon with COVID-19. I believe that most of us started out thinking it was going to be a sprint. when we started hearing about it in January of 2020, we got rumblings of it. And then when it really hit our facilities beginning in March of 2020, we were like, we threw all our energy, all of our resources into this, myself included. I remember the first nursing home that called me and said, we don't have gowns for C. diff, and we're going to duct tape garbage bags together. And I said, what? You can't do that. Little did I know what the next 2+ years would bring into our facilities. So I want to share with you that I recently ran a marathon just 2 weeks ago in Maui. And I know that sounds amazing, and it was, but I want to share with you, some things 5 things that I learned from running my marathon. Now, for those that you are not aware, a marathon is 26.2 miles. And so this is quite a feat. So some things that I learned while I was running this marathon is things take longer than we anticipate. We definitely have seen that within our healthcare settings. We know that, like I said, we thought we were going into this sprint, but it really has turned out to be this marathon. It's important to enjoy the journey. You know, every day we show up at our long-term care facilities and we look at the tasks ahead. We know what's in front of us. There's more regulations, there's more rules we have to follow, changes and all these different directions that we have to focus on. But what I have to say is we have to enjoy the journey. As I was running this 26 miles, it was important for me to look around, enjoy the scenery, enjoy what I was doing to help keep me going. It is what I found to be so important is that the support of our community keeps us going. It truly is our support, and whether that's our family, our friends, our long-term care colleagues, our QIOs, it really is the support that helps keep us going. For me, my marathon, my 2 sisters came out and support me. One was from Pennsylvania, the other Arizona, and they really helped encourage me as I kept going. The 4th lesson I learned is that we need to run the mile we're in. Oftentimes we look far ahead into the distance and we think, how am I ever going to achieve these goals? Where am I going? How am I ever going to reach these milestones? And what I learned is that we have to run the mile we're in, whether it's mile 1, whether we're just starting in our nursing homes, or we're brand new nurse, brand new administrator, or we're in mile 11 or 23. Like, we have to stay focused on what we're doing in that moment and in that time, and that helps us to keep going. And then finally, the unexpected does happen. You in this audience are no stranger to that at all. This is the world we live in, especially long-term care. And so for me, when I was running my marathon, no matter how prepared I was nutritionally or with the equipment that I had, I ended up with blisters that I didn't plan on and different nutritional needs. And so I had to adjust, and I had to be flexible and fluid right in time. And so this is definitely what we're experiencing in our long-term care. I would say long before COVID. In nursing homes, we're used to having, we're used to being creative. We call it creative healthcare. And so we are no strangers to this. So I just wanted to share some of those things that I learned, and hope that we can take those lessons. I'm taking those lessons into my work every day to help me as I grow in my practices. So, I want to take you guys to imagine. I just want you to kind of to focus and think about this, what it would feel like to have happy staff come to work every day. Now, hopefully you're not laughing at me or rolling your eyes, because I know that staffing is an incredible challenge right now. Imagine if your staff didn't call off and they didn't quit. So just maybe close your eyes and think about that for a second. What does that look like to you? And maybe even type in the chat what that looks like for you. And if it's been a while, what did it look like before? And then I like to say, heck, imagine what it would feel like if you enjoyed coming to work. Maybe you're burned out. Maybe that you're just like, this has just been, it's been such a long haul that you're just tired and you don't even enjoy coming to work anymore. So imagine what that would feel like to you. And I'd love to see some of your comments. I did this presentation last week with some certified nursing assistants, and they had all sorts of things to say. So I'd love to see what that feels like and looks like for you. And imagine what it would be like if your residents were happy and healthy, they're laughing, and they're not isolated in their rooms from an infection. Remember the days when we were all together and we were having dining and we didn't have to isolate our residents. We didn't have to put them in PPE. We didn't have to wear all the PPE. And then imagine, this is my fantasy world, a world without F880 tags. All right. So this would be an amazing world that we could live in, right? And so why am I having you do this? So I want to take you into the situation with infections in our long-term care facilities. So prior to the pandemic, there were 1 to 3 million infections every year in long-term care facilities. This led to 380,000 deaths. That's over 1,000 people dying every day from infections. And this also leads to the most frequent cause of transfers and hospital readmissions. These infections lead to 150,000 hospitalizations, $673 million in additional healthcare costs. And what if I were to tell you that up to 70% of these infections are preventable? So this is really important for me just to describe, because this was all before COVID-19. And we think that COVID-19 is our big problem. But what I want to describe to you is that the problem has occurred long before COVID-19 came into our world. And so why am I telling you this now? Because COVID-19, as the result, we've had over 1 million residents and 1 million staff that have contracted COVID within our facilities. And this has led to over 150,000 residents that have died and over 2,000 staff. These numbers have actually increased to a total of over 200,000 residents and staff. So when we imagine a world where our staff are happy and healthy and our residents are happy and healthy, this would involve without having these infections. Between 2013 and 2017, it was shown that 82% of nursing homes, they had an infection prevention and control deficiencies. That's that F880. Those are those F880 tags. And in 2020, IJs tripled from the year prior. So what I want to describe to you, well, so first of all, why should you listen to me? Why am I here today to teach you? And, why should you even listen to what I have to say? Well, during the pandemic, I've been in, now it's over 300 facilities that I have helped across the country, whether it's from Arizona to Michigan, Idaho to Texas. I worked with Doctors Without Borders' first ever US-based mission in Detroit, Michigan, and Houston, Texas, where we were able to support long-term care facilities with their COVID response. And as the result of that, the work for me has continued. I am continuing working with Michigan, Wisconsin, Minnesota with your Superior Health, providing on-site support to help you and assist you in making your infection control program the best that it can be. I was there when we closed our doors, when we closed our doors to visitors. And I've worked very closely with our healthcare staff, whether that's the environmental services or our laundry staff, and really partnering with you, educating and teaching, and perhaps going, even that one-on-one support. So I really understand the burdens in a very practical way. I understand what it's like to have a surveyor walk in your building in the middle of an outbreak when you don't have PPE, and they're head to toe PPE, but you're not, and just the disparity that feels. I know what it's like to have to reuse the PPE over and over and over again. And also when the government sent us the gowns that didn't quite fit well, we had to poke holes through the sides. And so I tell you these things so that you know that I understand where you've been and where we're going through all of this. It is probably one of my favorite things. I am an educator and I love to work with our staff one-on-one. And this is one of the staff that I was able to work with in Detroit, Michigan. And it was truly an honor to be able to do that. As the result of my experience in all of these facilities, I truly felt an obligation to write a book about your stories and to advocate for you, to demonstrate what we've been through, the landscape of infection control prior to COVID-19, what we've gone through, and then what the solutions are moving forward. And so I wrote a book that was launched a month ago. I hope you'll check it out and share it with your facility, because it truly is a call to action, but a call to celebrate you as our long-term care healthcare workers. So over the course of this series, I'm going to make a promise to you. I'm going to provide a roadmap that unlocks the key to successfully implementing IPC protocols in your community. This is related to COVID-19 and everything that's related to COVID-19. I want you to take these practices into your everyday working environment, even if you don't have COVID in your building, because this can help us reduce C. diff and CRE and UTIs and skin and soft tissue infections. And it can truly help us reduce the risk of all of these other infectious diseases that I demonstrated that we have running rampant in our healthcare settings. And you may think that, well, we don't have a lot of infections, but what I will tell you collectively as a nation, we do. And it is something that we need to work on and to help improve in our healthcare settings. I want to help support you in reducing your infections, including COVID-19, so that we can create a happier environment for you and your staff. Remember how that feels to have that happy staff and feel happy yourself coming into your building. And also to reduce those healthcare dollars. When we can reduce the dollars that go towards PPE or other in ways to mitigate infections, and we can put that money back into our staff and into our activities and into our residents. So those are my promises to you. And then over the series of the next, and then of course, here we go. This is what our goal is, right? We want to reduce having to keep our residents in isolation. We want to reduce the healthcare dollars, and we want to create a culture of joy and happiness within our staff. And y'all may be thinking right now, oh, this is a pipe dream. She's like living in the clouds. Remember, I told you, I'm in the buildings with you. I know what you're going through. And this is my hope for our facilities. And so in this series, over the 5 series, it's going to be over the next 5 months. We're going to do them once a month. I'm going to describe to you some of the best IPC practices, as well as describe the challenges that I've seen from over the hundreds of nursing homes that I've been in. And I think this is important because if it was just region-wide or statewide, it would be one thing. But when we start to see these practices across the country, and they're pretty much the same challenges, and then the same solutions can help, well, I'm all about sharing best practices. So that's what we're here to do. And we're going to talk about some topics related to hand hygiene. We're going to cover that today. We're going to talk about transmission-based precautions, the environment, cleaning, laundry, food services, and then of course, COVID-19. This will be wrapped up in all of them: prevention, containment, and mitigation strategies. And I would be more than happy, it is important to me to add value to you to these calls. I don't want you to come and just listen, and I want you to get something out of these calls. So if there are other topics, infection prevention topics that you want me to cover that you're struggling with, whether it's vaccinations, whether it's getting your staff to the testing, whatever it may be, I am more than happy to adapt and bring in these best practices for you. They'll be in there, but I want to make this valuable to you. So feel free, even in the chat, to go ahead and ask maybe some other areas that you need support with. That's what we're all about. And so today I want to talk about hand hygiene and some challenges and some best practices that I see very common in our healthcare setting. So the first thing, I have a question for you. And I ask this question in facilities all over the country. What is the preferred method of hand hygiene? Is it washing with soap and water or with alcohol-based hand rub? And if you could just put in the chat, I'll just kind of give a couple seconds. I just want to see what you guys think, what that best practice is. So Vicky says ABHR. Like to hear what other people think. So everybody is saying ABHR. We must have some very strong leadership on this call today, for sure. What I will tell you is when I do, and I encourage you to do this with your staff. When I do in-service trainings with our nursing staff, our housekeeping staff, our laundry staff, and I ask this question, I will have 99% of the people in the room raise their hand and say washing with soap and water. And they're shocked when I tell them within our long-term care environment, the best practice for hand hygiene is actually with alcohol-based hand rub. So those of you, you all said that, so that's amazing. And so yes, that's true. We want to make sure that we are using the alcohol-based hand rub is the preferred method. Of course, if our hands are soiled or we come into contact with any type of blood or bodily fluids, of course, we wash with soap and water. Certain infectious diseases like C. diff or norovirus the alcohol-based hand rub is not as effective in removing those spores, then we want to use that soap and water. And so if we know that, and the reason alcohol-based hand rub, it actually research has demonstrated that it actually kills, the kill time actually kills the germs actually better than soap and water. So some of the challenges that I see, however, with washing with the alcohol-based hand rub, the first challenge, and when I go into a building and I'm looking at the environment, the very first thing I do is I look to see what the staff have as far as access. Is it easy for the staff, if we know it's ABHR, how easy is it for them to use the alcohol-based hand rub? Do you actually have the hand sanitizer in the resident room and in the hallways? And so CDC does recommend that we have alcohol-based hand rub available inside of every room and then outside of every room if possible. And when I tell people that, they're like, that is way too much alcohol-based hand rub and the fire marshal won't allow it. And what I would challenge is so first of all, for our hand sanitizer, we can have it in the rooms, every single room. Outside, I encourage you can have it outside of every room or in between. Every room is nice as well. For fire code, it's 10 gallons per fire door, from door to door, it's 10 gallons. And that's just what's on the outside. That doesn't include what's on the inside. So that's plenty to have access to. Now, of course, we want to assess our population. If we have residents that are our dementia unit or our behavioral unit, we want to assess if this is going to be an increased risk for them. But what I will tell you is I would encourage you not to just have a blanket statement of it's a dementia unit or behavioral unit, so we don't have them at all. I've been into many, many facilities that even within their dementia units, they have strategically placed the alcohol-based hand rub. So it's going to be able to be easily accessible for the staff as well as protective to the residents. So I would encourage you to look at that. If you decide to increase more, which I encourage you to, then your vendors should provide the dispensers for free. If they don't, you can reach me and I will call your vendors, because it is a very common practice for them to supply the dispensers for free because you're buying their product. The way we want to think about it, and you'll hear this theme from me throughout all of these presentations, is we want these practices to be easy. We want to hardwire these practices into our staff so they don't have to think about it. And if we have hand sanitizers strategically placed, then they won't have to go look for it and they won't even think about it anymore. And it will really become part of their day-to-day life. Now, if you do have hand sanitizers in your room, look at where they're placed. Are they close to the door? So when the healthcare worker or visitor or anybody leaving the room, is it easy to actually access and then gel out? Or is it tucked away in the bathroom? Is it tucked away on the other side of the room where it's never being used? So look at the placement of your hand sanitizers and see if it's actually effective. You know, I mean, it's one thing to have it. It's another thing to be using it and make it easy. Is it behind a curtain so you can't even see it? So just consider that and take a look and see where your hand sanitizers are. If you have only one hand sanitizer dispenser in an entire hallway, I would highly, highly encourage you to add more. And the reason for this is because it's just not enough access. And so, for example, someone like me who's coming in the buildings, or your medical providers, your outside agency, maybe they don't go in the rooms. And so where are they going to conduct hand hygiene? And we want to think about that. If you don't have any sanitizers, I highly actually recommend starting to maybe place them on the outside first, so staff can get used to visually seeing them. And then it's going to automatically increase your compliance for hand sanitizing. Another tip I want to provide to you, and we talked about reducing those F880 tags. Oh, I mean, I'm right there with you guys. Let's reduce them. Let's change that whole process. But we want to, this is a really, this is a nitpicky, I would say, or a real easy target, I would say, even for surveyors, is make sure we're offering the residents alcohol-based hand rub before their meals and after toileting. Before their meals is really important. And I know specifically during COVID, it's been very challenging to actually to implement this because our residents are in their rooms, or it just makes it harder. So there's a couple tips I'd like to offer. First, you can have, there's little packets that you can order that they are alcohol-based hand rub, and you can offer them to the residents. Now, I'm a mom of 5, and so I am all about conservation and not wasting anything. So one thing you can consider, and I've seen this, is having like a basket on top of the food cart and placing those sanitizing wipes, those hand wipes on top of the cart. Because if you place them on every tray and they don't get used, and the residents don't have to do it, we just have to offer. But if they don't get used, then we could be wasting a lot, right? So maybe having a basket and we can offer it to the residents, and then we can help them open them as well. So that's some things I've seen. I've also seen, and you may see this frequently, or you may have this yourself, is a container that has a blue top, and it's specifically an alcohol-based hand wipe. And those are nice too to offer to the residents to be able to do the hand hygiene. I've seen in the dining room where we place hand sanitizer on the tables, or even those wipes on there. So it's very easy for the staff to say, if you'd like to wash your hands, here's the sanitizing wipe, or here's the sanitizer. So it's just something that it's a good reminder. Like I said, it can be, we'd hate to be tagged for that. And of course, we want to do this to protect our residents and protect them from potentially contaminating themselves as well. So of course, we all know about our hand hygiene moments, but what's interesting is how often are we doing audits to actually identify the observations that are being conducted. Many times when I talk to facilities, we know that the audits are being conducted for compliance. We watch our staff, we make sure they're washing their hands for the 25 seconds, that they're, turning the faucet on and off the right way and so forth. But how many of us are actually doing audits that are capturing the observations? And what I would encourage you, if this is not something you're used to, or you're like, it's just too time consuming, is you could literally even just do 2 observations. You could say, gel before going into a room and after going into a room. It's that second bullet point, before and after contact with a resident. Just starting there will really help you identify the practices in your building. And I would also encourage that you have secret shoppers, where you have people doing the audits that may not necessarily be identifiable as doing the audits, whether it's on their phone. You could just have just a simple note on your phone and, just do a check mark every time before or after they actually are doing the hand hygiene. It's important to capture the data and identify how often how often we're doing it. Typically, when I go into a facility, and this was even before COVID, I would do the observations, and it would seem that most facilities were about at a 50-60% rate for how to actually doing hand hygiene at the moments that they were needing to, because we get busy and it just takes extra time. And that's why it's important to have the easy access to the hand sanitizers as well. So we talk about before putting gloves on. This is very, very common. I don't see this happen hardly ever. I see, the staff, they'll just put the gloves on, but they won't use the hand sanitizer. So we want to ensure that they're putting the hand sanitizer on. They're rubbing it in the same way they would with hand washing for that 25-30 seconds, even if it's dry, to keep rubbing where it needs to go, because that's going to ensure that their hands are clean before they put their gloves on. Of course, before and after contact with the residents and these other areas as well. So you see this picture with this gal with the gown on, and she's got gloves on and this orange paint. Now, what the heck is this? So I want to provide you an easy and fun educational experience that I do with my staff and with the people that I work with. I bring up some volunteers, we garb up in the PPE, and then I do it as well. And I put paint on their hands. So this is paint, nothing else. Put paint in their hands and have them rub their hands together. I will do the same thing, but then I will go into this rogue mode and do everything wrong. I won't use hand sanitizer. They'll say, no, you need to use hand sanitizer. When I do use hand sanitizer, I wave my hands in the air to make it dry. And they're like, no, you need to rub it and wait till it dries before you put your gloves on. Sometimes I'll rub my hands on my pants, I'm trying to dry it that way. No, that's not the right way either. So make it fun. We talk about having happy staff and an environment that is fun, but oh my gosh, we're so sick of the education, right? And our staff roll their eyes. And if they have to hear the education one more time, they don't want it. They don't want it. So make it fun and interactive. When you have the staff put paint on their hands and rub it around, and I use brown paint sometimes too, and I'll say, this is C. diff room, okay? So that gives this visual and everybody's like, oh, that's disgusting. But I also tell them, we can't see germs. And so it's important for us to create some visual. I know some people use the glow germ to make sure it's a powder that can show if we're getting our hands clean. But this is fun in the sense for transmission-based precautions too. Sometimes I'll touch my face shield with it and my face mask. I'll pull my face mask down. So there's paint everywhere. So it gives the staff an idea of what our hands are carrying. and the importance, if we're touching our face mask or touching our shield, that we're using hand sanitizer before and after. And then it's also a lot of fun to see how they're washing or taking their gloves off, because typically when you see staff removing their gloves, they're just flipping them off. And so they're very, very careful when they have paint on their gloves not to just fling them off. So it really does a lot. It's a practical way that helps. It's fun. The staff get engaged, and it really does bring home the best practice of hand hygiene. So, so next time in our presentation on June 15th, I want to talk about environmental cleaning and laundry services. These are the most common areas that I see transmission of germs and just the risk of transmitting of viruses. You can see just an example of this trolley cart with a toilet bowl brush on it next to the eye protection. And if you think that this is uncommon, I'm going to ask you to think again. And just a question for you to think about during the time between when we meet again is it a common practice in your facility to have your housekeepers clean the bathroom first? And many of you may be rolling your eyes and say, that's disgusting, we would never do that. But I'm asking if you're sure about your answer, because this is actually a very common practice. So we're going to go deep into environmental cleaning and really how this practice alone can help you prevent spreading and transmitting infections in your facility. COVID and C. diff and norovirus and these infections that are really easily transmitted in within our environment. I just encourage you to check out our website. Know that we're here to support you. Again, we thank Superior Health for this opportunity to provide training and support. And our website is ipcwell.com. And let us know if you have any questions, and know that we're here to support you as well. And from there, I'll turn it over to Kim.
Thank you, Dr. Buffy. That was an excellent presentation. I encourage all of our participants at this time, if you have any questions for Dr. Buffy. I know that she did her focus on hand hygiene. So if you have any questions about that, maybe certain practices that you are experiencing with hand hygiene. I know she had used her experience with the paint. Maybe someone else, maybe there's another nursing home that's doing something similar or something a little bit different to get their point across, but still in a fun way. We love to learn from each other. So if you have anything on that, that would be great. Any other questions too that you may have for her? I'll give you a second to think about that. So it looks like Diane here says, I have done hand hygiene demonstrations with chocolate pudding in place of the paint. Well,
I love that.
I love that. And what actually, man, it's got to smell a heck of a lot better than paint. It's a great strategy.
Yeah, and that might be, so for me, where I travel a lot, taking paints with me can create some challenges sometimes. So what I love about that is it's easily in your facility, maybe chat with the food service director before you're going to do that and say, hey, can you make up some chocolate pudding or whatever? I think I love that. That's a great strategy. And then it looks like there was a question about, are nursing homes still handing out pocket bottles of ABHR, and is this an effective strategy?
It's a great question.
So I'd love to hear about the nursing homes. As if they're still handing them out. I know for what I experience, this still is a common practice, specifically in facilities that do not have hand sanitizer dispensers. And I commonly see this in the facilities that have more of the, it's like a home-based based model. I can't think of the name of it. There's a specific name where it's very much the home environment. And of course, this is how we treat all our buildings. But, so when it's kind of a policy of the facility not to have the greenhouse model, but there's another name too, Chrissy, I can't think of it. But anyway, when we don't have access to hand sanitizer, often when I say, well, how are staff washing hands? They say, well, they carry the hand sanitizers in their pocket. And so I would encourage you, now you can do that. And I don't love anything in the pocket. And we know we don't want to put clean gloves in the pocket because they're not considered clean. But if we take the hand sanitizer out of our pocket, and at least with one hand, we're putting it in our hand, and then with the other one, cap it and put it back in our pocket. When we're doing our hand hygiene, we're pretty much killing anything that was on our pocket. So, I mean, that can be effective, but it's a convenience thing for me. And are the staff really stopping and pulling out the hand sanitizer every time they walk in a room and then pulling it out again every time they leave a room? So I would just encourage you to watch and see if that's actually an effective strategy. It could be. I mean, your model may work so well. And so I would just encourage you to not just assume it's working, but evaluate it and really monitor those observations to see if it actually is working. Because in my experience, the staff are so busy, they're going in and out of the rooms, and they don't remember to grab that hand sanitizer in their pocket for every opportunity. But if they have it mounted on the walls, it's easy to see and it's easier to adhere to.
Perfect. It looks like we also have another question. It's from Mitchell, and it says, this isn't it's not a super hand hygiene related, but what is your viewpoint for cohorting COVID observation patients?
Yeah, so CDC recommends that if you have a resident, I'm assuming observation means maybe a new admit that's not up to date, and they're on that 7 or 10 day quarantine, depending on your testing. And we really don't want to cohort them because we don't know for sure if they actually have COVID or not. And so if one of them ends up getting it or has it, and then that's possible to transfer that to their roommate. So I know facilities have had to do this based on just staffing needs. But really the best practice, if you can, is to have them in their own private room. That's of course, if they're observation. If they both have the infection that's confirmed, then cohorting is appropriate because they both have the same infectious disease. As long as there's not some other infectious disease, then that would be more appropriate. So I hope that helps.
Yeah, did that answer your question, Mitchell? Excellent. Good. Perfect. Well, we're still waiting to see if you come up with some other questions. I know, Julie, did you have some questions maybe you'd like to put out to our participants? Maybe they'll have some input for your questions.
Yeah, absolutely. I really like the activity that Dr. Buffy shared about the paint. And I know we've had some other people chat in about the strategies that they're using, but I'm so curious. So if other people have ways that they're going about kind of training on hand hygiene and getting everybody together to learn about this that are creative, I think that would be super helpful to share. So again, feel free to drop that into the chat, or you can go ahead and unmute yourself and let us know too. And then also, how often is it recommended that this hand hygiene education is taking place? Dr. Buffy, I don't know if you want to weigh in on that, or our nursing home leadership that's attending today, if you have a best practice that you wanted to share too.
I'll jump in while people are putting in the chat. And, you at a very minimum, once a year during your competency training, at a very minimum, and on new hires, right? So, if you have your new hire orientation, it would be great to do it then. And then of course, at a minimum once a year. But I also would do it based on your audits. So if you're doing your audits and you're realizing like, oh, we're only at 50% observation, only 50% of the hand hygiene opportunities are being met. So maybe then you increase it. Maybe we do it on a quarterly basis. And maybe you can use different techniques. Like I know you can buy the glow germ powder and you can get that on Amazon. And I have that too. It's a lot messier for me. So believe it or not. And so I don't always carry that, but it has a little black light. And so you can use that, have your staff wash their hands and just kind of shine the black light to see the areas that are still dirty. It's just a nice visual as well. But really, I would let the data drive how often, but like I said, at a very minimum during new hire orientation and at your for annual competencies as well.
That's really helpful. Thanks, Dr. Buffy. And I do want to still pose that question to the group too. So if you have any feedback, feel free to drop that into the chat or go ahead and unmute yourself. And then I know we had another question come in. There was that question about cohorting COVID observation patients. But while we have Dr. Buffy here and all of her knowledge and experience, any other questions? What have been those most challenging IPC, infection prevention and control protocols that your teams have navigated or are currently navigating right now? Is there anything that's challenging you that you want to get feedback on from either Dr. Buffy or your peers on the call today?
While people are thinking about that and probably putting their questions in chat, or please feel free to just unmute yourself and talk, because then I don't know, sometimes when I type, it takes me forever to get what I want to try to say, right? But you said something earlier, Dr. Buffy, and I know for a fact someone in our audience had asked this question before, and that was, how do I get my staff to test? That has come up before in our events in the past. And I would love to hear, and I'm sure then if the audience has asked that before, they would like to hear what you have to say about that.
Well, that's a great question. And it's funny, right before you said that, I was thinking, I wonder if I should say anything about testing because there's two challenges, and we'll talk about this more, but two of the greatest challenges I see in long-term care right now are compliance for wearing the eye protection. That seems to be 100% just almost impossible to get compliance on that. And then the other is with testing. And what's made it more challenging is that when the staff were fully vaccinated, they didn't have to test that twice a week if you're in moderate to substantial spread. But then when it was changed to up to date, then anybody that's not up to date has to do that once or twice a week. You have to follow that the protocols for testing. And so first of all, my highest recommendation is to not give up on the staff and continue to encourage the up-to-date and vaccinations. That's number one. And, before I met this one IP at a facility, I think my own personal belief was, once they've said no 100 times, just leave them alone. But I've changed my mind a little bit because I met with an IP that continued to not harp, but just have a conversation about the importance of the boosters and the vaccinations and provide that education. And what she saw was that as she continued to bring up that topic, the staff and the residents actually had would oftentimes change their minds based on what they were seeing with loved ones or friends that were ended up hospitalized or had complications from COVID. And so I guess my whole point of that is, first of all, trying to encourage the staff to continue to get the boosters. That's really important. And then the next thing I've learned is having a consistent schedule is very important. Having like a twice a week schedule is helpful. However, of course, we can't accommodate everybody in that regard. And so being able to have the availability 24 hours, but if you could do the bulk in like a scheduled time, that will help. Also, there are facilities that have, they're able to have the staff test themselves you do want to make sure that they've gone through the training for the testing, and that is per your CLIA waiver, that they actually have tests, they sign off, have them actually sign an actual competency training, that they understand how to test themselves. And so those are just some of the ways that are helpful in improving compliance. If you do have the staff test themselves, you need a follow-up practice. So make sure that you are following up, that the test results are being read at the right time. Like, we wouldn't want them to leave prior to that 15 minutes. And then also following up just to make sure everybody's meeting those requirements. So I hope that was helpful. Those are some tips that I've seen facilities successfully implement for their testing protocols. So I do see a question about goggle adherence. I don't know if you said that before or after I mentioned that. We are seeing people wear less glasses and are having less adherence, of course, with this. This is the number one of the, and testing. Those are probably, like I said, the two highest issues that the leadership is challenged with. So first of all, the challenge is just everybody's a bit fatigued, right? They're fatigued. They're like, I'm over all of this. And so I think just having the ongoing education regarding why we're wearing it is important. Even, discussing, the droplets more. I know we've already discussed that a lot, but, having those conversations is important as well. The CDC recommendation is that the eye protection is worn during resident care, but I know that facilities that have that as their actual policy just during resident care, it's harder to implement, because then you're taking your glasses off throughout the whole day, and then so that's a little harder. So I would recommend having it just kind of across the board policy, like if you're in the resident care area, to wear that eye protection. And then that, hopefully will help as well. I personally, because I wear glasses, I wear a face shield, and it's easier for me versus the goggles are more difficult to see out of. So just checking in with your staff. But the bottom line, it comes down to this, as well as compliance for hand hygiene and everything else. It's just something that we have to continually educate and train and encourage. One of the things I will add with this is that we want to make sure that this is very common too. I don't see this practice occurring, especially now. We're not cleaning our eye protection. We're reusing it, but it's not being cleaned. And if it is being cleaned, the cleaners, and you may ask why. We have cleaners available. We have sandy wipes, we have bleach wipes, we have the cleaning product available. But some of those products will leave a very strong film on the eye protection and an odor. So the staff are like, they don't want to do that. And I don't blame them. I had a nurse in Utah a year ago show me the Lysol disinfectant wipes. They're in the yellow container. You can get them at your local grocery store. They are EPA registered and they're effective against COVID. It's what I use now, but they don't leave a streak. They don't leave a film. And they're like a 2-minute contact time, I believe. The staff like them much better. So just look at some of those things as well. That may be helpful, but I recommend that to all the buildings now, because if the staff are cleaning with like those products that harsh and leave a film, they're just not going to do it, because it's going to take too much time and then they can't see through them. So having a product that might help with that cleaning as well.
I know that you're not endorsing Lysol, but
I don't endorse anything.
I know, but what type of, no, I know, but I didn't hear the whole, since I didn't catch it all, I just wanted to say what product was it again?
Yep. So it's thank you. I do not endorse any products.
I know that, but I just wanted to make sure everybody.
But I share what other people use when they tell me it works.
Right.
So it's the Lysol disinfectant wipes. They're in a yellow container. And I share that because the staff, they use them, and I want to share what the staff will use. So yeah.
No problem. All right.
Well, I know we have a few minutes left, so any other questions, any infection prevention and control protocols that your team is navigating right now that you want to ask any questions about? I know, Dr. Buffy, you mentioned the other topics that you're going to be covering in this series too. So that's transmission-based precautions, environmental cleaning, laundry, food services, and then COVID-19 prevention, containment, and mitigation strategies. So it would be kind of cool too to get a pulse from all of our attendees today. What topic are you most looking forward to hearing more about of those topics that Dr. Buffy is going to be covering? Or Dr. Buffy, I know you put this out there too, any other topics that you want more information on that Dr. Buffy can cover or that we at Superior Health can take back and keep in mind for a future session. Go ahead and drop those in the chat, or again, go ahead and unmute yourself. All right, well, hearing none, Kim, I'll go ahead and turn it over to you.
Yeah, for sure. Dr. Buffy, is there anything in particular, or maybe just a couple of tips or what have you, that you have maybe seen in regards to, it doesn't necessarily have to be hand hygiene, but that just has also stuck out almost like a sore thumb that you know that is, oh, surveyors will probably catch it too when they walk in the door. Any just like a couple of last words on something that you may have noticed that is an easy, well, I don't know, things ever an easy fix, but something that you might be able to close with today?
Sure. Yeah, there's a lot that, and we, like you said, we'll cover that in the other topics as well. But one of the things, and I know, so I'm based out of Arizona. One thing I just learned is the screening process for COVID is still at the like tippy top of the surveyor tags. And so it makes sense to me because we've gotten a little lax. It actually can require an additional staff. And so what I would encourage you to do is go through your screening for COVID as people enter the facilities. How are the staff being screened? How are the visitors? There doesn't seem to be an issue with visitors as much, but the staff, I've seen more of the lax practices, especially if you have a separate entrance for the staff to screen in. One of the recommendations I provide is make sure you're actually verifying on some type of a scheduled basis that the staff are actually screening in, whether that's through some type of electronic means like a kiosk or even if you have a paper, just compare that with the staff that are working, because I've seen lots of facilities tagged for non-compliance on screening. And I'll just tell you a very brief story. I was in a facility a few months back, and the infection preventionist was really struggling with having the staff do the screening. And as she's just like, I just can't get them to do it. And they didn't have somebody there to sit at the desk. But when I was leaving the building, there were 3 staff coming in for their shift. And one of them said, well, aren't we supposed to screen? And then another one said, no, we don't do that anymore. So definitely a good idea to revisit that, to see how it's going, and to make sure that it's just as airtight as it was 2 years ago, because that really is our critical place of helping to prevent people coming in that may be infectious, and to help keep COVID out of our building. So just keep an eye on that as well.
That's a great tip, Dr. Buffy. All right, well, we're just coming up upon the hour. We have 2 minutes left. I do not see any other further questions or comments in chat. So I wanted to thank you again, Dr. Buffy. It's been a very engaging session. I love hearing all of your different tips and tricks to help the nursing homes to improve their infection control processes. And we look forward to having you on the next 4 sessions that will be coming up. The next one that you'll be here with us is in June. Looks like June 15th, you'll be with us again. So with that, everyone, thank you for being here. Thank you for participating. And we will see all of you back here again next week.